Alright, this is the assessment assimilation video. So you're going to start up with scene size up. You're going to go through your, depending on if it's trauma or medical, MOI or NOI. So you're going to, as you pull up, you're going to do your windshield evaluation of the scene. Do you got 2 cars, heavy front end damage on both? Do you still have people in the vehicles, or are they out walking? Do you have vehicle off of ravine? Stuff like that. And you can kind of tell by bystanders too, how they're reacting, how bad this wreck is going to be, or whatever it may be. As far as NOI, you're looking at their color and their muscle tone, their awareness. How many patients do you have? Do you need help, or can you handle it on your own? Do you need helicopters? Do you need special rescue teams, hazmat teams, anything like that? And then on a medical scene, you want to make sure that there's no trauma. A medical could be a stroke. Well, that stroke patient fell, so you also have trauma. Or on a trauma, you always want to look for medical. Just because it's a car versus tree doesn't mean they didn't have an MI or a stroke or a diabetic episode that led to the MVA. So you want to be checking for stuff like that as well. You also want to be on the lookout for abuse. As far as your general impression, the 3 things I always ask myself is, are they dying now, are they dying later, or are they just not going to die at all? And answering those 3 questions, having one of those answers will set the entire tone for the call. You're either going to be in their actively dying mode, and you're just doing everything you can to keep them alive, or it might just be, a real basic call that you end up PRCing. Is it something you can fix and you need to sit on scene and splint it, or give them a little oxygen, or just reassure them, do whatever? Or is it something you can't fix and they need to get to the hospital now? Am I in over my head? There's a lot of stuff we can handle on our own. There's a lot of stuff that we need flight for, we need multiple ALS units for, we need trench rescue, whatever. And then, do I need help now, code 3, or can it come in code 1? And that, could, as far as EMS, would relate to like supervisor or second unit, or for me in fire, a lot of times I'm having to send an ambulance code 3 that was initially dispatched code 1 or something like that. We're going to look at their level of consciousness. Are they alert, verbal, painful, or unresponsive? And then estimate the GCS. That L there is a typo. Estimate the GCS. A lot of times at this point in my patient survey, I'm not getting a true GCS. I'm just kind of going to estimate it roughly where they're at. And then you want to know, are they altered? Because an alert patient can very much be altered. Verbal, painful, unresponsive patients are almost always altered. But an alert patient, you want to make sure that just because they're awake and alert doesn't necessarily mean that mentally they're intact. As far as the ABCs, is the airway patent? Is it self-maintained? Are you going to need to insert an adjunct? Is there any swelling? Anything like that that's going to change over time. So you might have a little bit of bleeding. Is that bleeding going to increase over time, where you might lose what is now a patent airway? As far as breathing, you commented on one of my assessments the other day that you don't like to assess lung sounds at this point. I do, and I can change that for the course of this class, but I like to know. Some people just hide it really well. Kids hide it really well. Sometimes just seeing chest rise or just seeing their work of breathing doesn't always tell me the full story. So I like to know, are they breathing? And if they are they doing it good enough? Do I need to help them? Is there equal chest raise? Is there good lung sounds? Especially with the asthma, stuff like that, where you don't necessarily know the whole story. As far as circulation, is there bleeding? Do they have a good regular pulse? Their skin temperature and condition? Do they have a fever? Shock is going to be extremely evident by color, temp, and condition of the skin. It's one of the first places you see it. It's one of the best places to see it. The rapid exam is head to toe. I'm looking for anything that's going to kill them, and if so, I'm going to handle it right then and there. What do I need to do about it? Is it something I can do anything about, or do I just need to get them to the hospital? I'm going to take an inventory of the patient so that I know what changes by the time I'm going down the road, and I'm going to expose them as needed by cutting their clothes off. Sample and OPQRST is the story of the patient, tells you what's going on right now, what has been going on, and how they might deteriorate over the next 10 to 20 minutes while you care for them. There's their vitals, so you want to make sure that they're roughly in that range. You want to make sure that they're normal for them. because some people are chronically hypertensive, so you're not going to get that systolic below 140 or whatever. Especially some diabetics, might say, well, she was running low today, and you ask them what low is, and it's 200. Your secondary exam is, did you find anything you missed? Are you confused about the presentation of your patient? They're presenting a way that you don't quite expect, so you need to go back and you need to look at it some more. And that carries over into your reassessment as well. Make sure that your patient is stable. If they're deteriorating, make sure it's because of their condition and not because of lack of what you've done. If it's a treatable condition, you need to be involved and you need to be treating it. So that deterioration needs to be managed as well as you possibly can. And you need to go through and intervene or check your interventions, make sure that everything is appropriate. You might have started with a cannula, but now you need to upgrade to a non-rebreather or BVM or something like that.